Dear doctors, today we will be talking about cardiac arrhythmias. You know, this topic is very important, and all your life you will keep on getting the patients who have different type of cardiac rhythm problems. When we will talk about cardiac arrhythmias, in the topic of cardiac arrhythmias, we will discuss number one, what is normal cardiac rhythm? What is normal cardiac rhythm? Number two, how we define cardiac arrhythmias. Number three, what are the mechanisms? What are the mechanisms of cardiac arrhythmias? Mechanisms. And of course, then we will talk about that what are the types of cardiac arrhythmias and what is the relationship with ECG. Right? Again, let me repeat what we are going to discuss today. Number one, what is normal cardiac rhythm? Number two, what is abnormal cardiac rhythm? Number three, what are the mechanisms which produce cardiac arrhythmias? What are the types of cardiac arrhythmias? And what is the relationship of abnormal cardiac rhythm with ECG? Right? So first of all, we will talk about what is normal cardiac rhythm. You may be thinking, why it is so important to know the normal cardiac rhythm? Answer is that cardiac arrhythmias are defined as when heart deviates from the normal rhythm. What are cardiac arrhythmias? Cardiac arrhythmias are said to be present whenever heart deviates from or goes out of the normal rhythm. So first of all, we should be able to define very, very clearly what is normal cardiac rhythm. Now, let me discuss with you the what are the different criteria of normal cardiac rhythm. All of you must be knowing that for normal cardiac rhythm, one of the very important criteria is that heart rate should be somewhere between 60 and 100 beats per minute, right? So let's suppose on this scale, we drive the heart rate. Here it is 60 beats per minute, and here it is 100 beats per minute and 60 beats per minute. Now, normal cardiac rhythm is having number one criteria, the heart rate has to be between 60 and 100. If heart rate is less than 60 or more than 100, we say heart has gone out of rhythm, right? So, criteria number one, heart rate between 60 to 100 beats per minute. But then there is one more requirement for the cardiac rhythm to be normal. And second requirement is that not only heart rate should be between 60 and 100, there is another important requirement that every heartbeat should be originating from SA node. If every heartbeat should be originating from SA node, it means that that is the second criteria, that every heartbeat should be originating, origin should be from, yes, origin should be from, yes, very good, SA node. If, for example, some impulses are not taking origin from SA node, they are taking origin from atria or from the ventricle or from the AV node, then these are not considered as normal cardiac rhythm. Number three criteria is that all electrical impulses or cardiac impulses should not only take origin from SA node but should also pass through normal conduction pathway, right? So we can say that cardiac impulse should propagate through, yes, cardiac impulse should propagate through normal conduction pathway, right? Again, let's discuss first three criteria. If I have to declare your heart rate is normal, it means number one, your heart rate should be between 60 to 100. Number two criteria, every impulse should be originating from SA node, right? Let's suppose here is the heart. Yes, this is the atria and here are the ventricles. Here is the SA node, which is the normal pacemaker of the heart. Here is AV node, which is an excitable tissue which act as an electrical connection between the atrium and the ventricle. And after that, current passes through bundle of hairs and bundle branches. Now listen. That second criteria is what? That this is SA node. So every impulse should take origin from SA node. Third criteria is what? That current should pass, once it has originated from SA node, it should pass through normal conduction pathway. What is normal conduction pathway? That from SA node, it should spread to the atria. From the atrium, depolarization should come to the AV node. Then from the AV node, it should come to the bundle of hairs, and then current should pass through bundle branches, and eventually through the Purkinje system, current should go to the final fibers which terminate, which supply the myocardial cells, ventricular myocardial cells. So, if your heart rate originates from SA node, passes through atria, through AV node, through bundle of hairs, bundle branches, and Purkinje fibers, that is the normal pathway of conduction, then we say your rhythm is normal. And one more criteria which is there is that while cardiac impulse should pass through the normal pathway, it should also pass through the normal pathway with normal velocities. For example, a normal cardiac impulse should move with moderate speed through atrium, should be very, very slow in AV node, and normal cardiac impulse velocity should become very fast when it is passing through Purkinje system, right? So what I really mean that not only cardiac impulse should go through normal pathway, but it should pass through normal pathways with normal velocities, velocity, right? What I mean by normal velocity, that in atrium, cardiac impulse should be with moderate speed, 1 meter per second. AV node, cardiac impulse should be very, very slow. And in bundle of hairs, bundle branches, and Purkinje fibers, cardiac impulses should become very fast, right? So these are the basic criteria which are required to declare any person's heart rate and rhythm as normal. So it is just like a 5-pointed star. You can get a star for normal rhythm, which has how many points? 5 points. Point number 1, rate is between 60 to 100. Point number 2 is every beat is of sinus origin. Point number 3 is that there should be normal, yes, normal conduction pathway, right? And then next point, point number 4 is, yes, it passed through normal pathway with normal velocity. And point number 5 is just for a tail. Is that right? So these are the basic points. If these are met with, your cardiac rhythm is normal. And due to any reason, at any point, if your heart deviates from this thing, we say there is cardiac arrhythmia is present. Heart has lost the normal rhythm. Again, if heart rate goes less than 60 or more than 100, it is cardiac arrhythmia. If origin of impulses is other than sinus, it is cardiac arrhythmia. If conduction is not through normal pathway, it is cardiac arrhythmia. And if velocity through the cardiac pathways, cardiac impulse velocity through the normal pathway is abnormal, again it is cardiac arrhythmia, right? Now I will introduce few more terms related with the cardiac arrhythmias. Number one, if the rate become less than 60, the conditions are called bradyarrhythmias. Bradyarrhythmias. Yeah, bradycardias. Many people call it bradycardias, or we simply say these are arrhythmias in which heart is having slow rhythms. So when there are slow rhythms, we call them bradyarrhythmias. And when heart rate is more than 100, right, whatever type of arrhythmia is there, as a group, that arrhythmia is called, yes, tachyarrhythmias. So one way to classify the arrhythmias of the heart is that the slow abnormal rhythm and the fast abnormal rhythms. And slow abnormal rhythms are called bradyarrhythmias, and fast abnormal rhythms are called tachyarrhythmias. Now, about the tachyarrhythmias, again there is a simple classification. If tachyarrhythmias are between 100 to 150, if tachyarrhythmias are somewhere between 100 to 150 beats per minute, we call it simple cardiac tachyarrhythmias, simple tachyarrhythmias. And if heart rate is somewhere between 150 to 250, electrical activity in the heart has gone somewhere between 150 to 250, we call this condition, usually this condition suddenly appears and then disappears. Due to this reason, because such arrhythmias suddenly start and usually suddenly terminate, we call them paroxysmal tachyarrhythmias. And then if electrical activity in the heart becomes faster and it's somewhere between 250 to, yes, 350 activities per minute, these conditions are called flutters. Of course, if such electrical activity is present in atrium, then it will be called atrial flutter. And if such activity is present in ventricle, we call it ventricular flutter. If someone is so unfortunate that electrical activity in the heart or some part of the heart goes above 350 times per minute, right, then we say patient is having fibrillation. Patient is having fibrillations. About the fibrillation, again it's very simple. If electrical activity in the heart is more than 350 and this is happening in atrium, this will be called atrial fibrillation. Or if electrical activity in the heart is more than 350 and unfortunately if it is happening in ventricles, which are the major pumps, then we call it ventricular fibrillation. Is that right? Of course, a very dangerous medical emergency. We'll discuss this thing in detail later. Then, one thing more, that when heart rate becomes less than 60, we call them bradyarrhythmias, and if it is somewhere between 40 and 60, then these are called mild bradyarrhythmias. These are called mild bradyarrhythmias. And if it is between 20 and 40, we call it moderate bradyarrhythmias. And if some very unfortunate person is having heart rate less than 20, of course this must be considered as a severe, yes, bradyarrhythmias. This must be considered as severe bradyarrhythmias. Now, we have classified cardiac arrhythmias in one way as bradyarrhythmias and tachyarrhythmias. And then we classified tachyarrhythmia between 100 and 150 as simple tachyarrhythmias, and rhythms, electrical activity in the heart between 150 to 250, we called it paroxysmal tachyarrhythmias, and any activity, electrical activity, which is more than 250 but less than 350, that is called flutter. And when electrical activity in any part of the heart becomes more than 350 per minute, we call it fibrillations. So this was one way to classify cardiac arrhythmias, in which we have already discussed that if electrical activity is less than 60, these are bradyarrhythmias. If it is between 40 and 60, mild bradyarrhythmias. If it is between 20 and 40, it is moderate bradyarrhythmias. If it is less than 20, we call it severe bradyarrhythmias. Now, there is another way to classify cardiac abnormal rhythms. The second way to classify abnormal cardiac rhythm is according to the main site where the abnormal rhythms are generated. For example, rhythms which are coming from SA node. And if any abnormal rhythms which are coming from SA node, we call them sinus arrhythmias. They are called sinus arrhythmias. Sinus arrhythmias mean when abnormal rhythm is due to some problem within SA node, right? Then those abnormal rhythm which are due to abnormal activity within the atrial myocardial tissue are called atrial arrhythmias. They are called atrial arrhythmias. And of course, when there are abnormal rhythms related with AV node or related with the junction, right, junction between the atrium and the ventricle, of course that junction is AV node. If abnormal rhythms are originating from AV node, we call them junctional arrhythmias. We call them junctional arrhythmias, or we simply call them nodal arrhythmias. Other name is nodal arrhythmias. So junctional arrhythmias or nodal arrhythmias, one and the same thing. And if there is abnormal rhythm originating due to abnormality within the ventricle, we call it, yes, we call it ventricular arrhythmias. Ventricular arrhythmias, right? And sinus arrhythmias, atrial arrhythmias, and junctional arrhythmia. All of them originate above the ventricular tissue. Again, sinus arrhythmias from SA node, atrial arrhythmias from atrial tissue, junctional arrhythmias from AV nodal tissue, right? These three arrhythmias take origin above the ventricular area. Due to this reason, some people prefer to call all these three arrhythmias, they lump them together as, they lump all these three arrhythmias together as supraventricular tachyarrhythmias. Again, let me tell you what is the concept of supraventricular tachyarrhythmias. If tachyarrhythmias are of sinus origin or atrial origin or junctional origin, of course, tachyarrhythmia from any of these three places are definitely taking origin above the ventricles, right? And you know, ventricles are the real pump. They are the major pumps in the body. They are of prime importance to us to maintain the cardiac output. So we simply classify the tachyarrhythmias, and the tachyarrhythmias originating above the ventricles and tachyarrhythmias originating from the ventricles or within the ventricles, right? And tachyarrhythmias which take origin above the ventricles, they are called supraventricular tachyarrhythmias, right? And supraventricular tachyarrhythmias are all those tachyarrhythmias which are either taking origin from SA node or taking origin from atrium, or they are taking origin from junctional tissue. Is it clear? Right. Now, we will be talking about the mechanisms of cardiac arrhythmias. Mechanisms of cardiac arrhythmias. Basically, primarily there are three mechanisms. Number one, there may be increased automaticity. You know how do you define automaticity? Automaticity is defined as a property of any excitable tissue which can undergo depolarization spontaneously, right? And if some cardiac tissue develop high automaticity tendency, it means some cardiac tissue develop the power to produce depolarization spontaneously but very rapidly. Of course, that will start tachyarrhythmias, right? So one mechanism is increased automaticity. Second mechanism is triggered automaticity. And third mechanism is phenomenon of re-entry or circus movement. I will explain all of them one by one. Circus movement. Now, first I will explain the concept of increased automaticity. Let's suppose here is a cell with SA node, and as we have discussed in previous lectures on the electrophysiology of the heart, we have already discussed that SA node work as a pacemaker because it has a tendency to undergo depolarizations spontaneously. I am drawing here the electrical activity of SA node. You know, this is the resting membrane potential of SA node. This is the threshold potential. In SA node, many cells, in SA node, the cells have leaky sodium channel. So when sodium trickles into SA nodal cells, the resting membrane potential cannot really rest because the incoming sodium will take the resting membrane potential towards the threshold. As soon as resting membrane potential reaches up to threshold, what really happens that there is opening of voltage gated calcium channels, and lot of calcium comes in, and this produces calcium dependent depolarization. And of course, when depolarization is done, then there is opening of voltage dependent, yes, potassium channels, and potassium efflux, that is the loss of potassium from the cell, takes the membrane potential back to the resting level. It means membrane become again repolarized back to its normal resting membrane situation. And as you know that as soon as membrane will go to the resting level, again sodium will come in, take the resting to threshold, again calcium dependent depolarization will start, and potassium dependent repolarization will start. So and so forth, SA node undergoes spontaneous depolarizations and act as a pacemaker for the heart. Now, how this automaticity can be increased? One way is that let's suppose you stimulate the SA node with epinephrine or norepinephrine. When it stimulates its receptors on the SA node, you know these receptors are beta 1 adrenergic receptors. So when epinephrine stimulates its beta 1 adrenergic receptors, what really happens that stimulates intracellularly G stimulatory proteins, and which eventually lead to phosphorylation of some additional calcium channels, and additional calcium comes in. So we can say when epinephrine act on this automatic tissue, it load that tissue with the extra cations, or it load that tissue with the calcium, and this added calcium which comes into the cell that help the cell to move towards the resting membrane potential to move to the threshold potential more rapidly, and there is more frequent production of action potentials, and we can say that normal automaticity is enhanced or increased after the action of epinephrine on SA node, and SA node will be firing more frequently, and if SA node is firing more frequently, we say there will be sinus tachycardia. So this was one example that how increased automaticity can produce tachyarrhythmia. Now we come to another example where triggered automaticity can lead to tachyarrhythmia. Let's suppose we talk about a ventricular cell. This is a cell from the ventricle, and first I will draw the normal ventricular electrical properties. In a normal ventricular cell, here I am showing resting membrane potential, and here I am showing threshold potential, right? Now, normally what happens that in ventricular cells, resting membrane potential keep on resting until the nearby cell throws some cation into the cell, and this cell will undergo depolarization, and it has a long plateau, right? And after that, now this is the electrical activity of ventricular cell. Here it is sodium dependent, of course, depolarization, right? And this plateau is produced when potassium is leaking out but calcium is entering into cell, right? When potassium is going out and calcium is coming in, so there is loss of potassium, gain of calcium, or loss of positive ions as well as gain of positive ions, so there is no significant change in the electrical potential of the membrane. And of course, eventually calcium stop coming in, but potassium keep on going out of the cell very rapidly, and that produces repolarization, right? After that, depolarization and eventually repolarization, membrane potential come back to the resting value. Now, sometimes ventricular arrhythmias may be produced due to a fact that from here a new action potential takes off. And if action potential takes off at a very early time, this is called early after depolarization, because this was the original depolarization, and this depolarization has started after this triggered depolarization has started after the spontaneous depolarization, but this has started at a very early time, so we call it early after depolarization. And sometimes it happens that resting membrane potential is fluctuating, and if it touches the threshold, a depolarization is produced, but this depolarization is not so early, so it is called delayed after depolarization, delayed after depolarization. So let me tell you, number one, when there is triggered automaticity, we are talking about triggered automaticity. When there is triggered automaticity, then what really happens after the spontaneous depolarization, there is triggered depolarization. Now this triggered depolarization may be early or triggered depolarization may be late. If triggered depolarization is early, we call it early after depolarization, and if it is delayed, we call it delayed after depolarization. So whenever membrane properties are abnormal and they are producing early after depolarizations or they are producing delayed after depolarization, again tachyarrhythmias are produced, and such tachyarrhythmias are called triggered automaticity induced tachyarrhythmias. Again, what are the examples of, what are the mechanisms which can produce post delayed after depolarization? Again, if these cells become ischemic, if myocardial cells become ischemic, or these cells become injured, the membranes become injured, or due to any reason these cells load lot of cations, for example catecholamines. Catecholamine can lead to loading of cations. So when a lot of cations are loaded, resting membrane potential cannot rest, Either the membrane has ischemic injury or it has any type of injury, for example by inflammatory products, or catecholamine is stimulating the membrane. Under all these circumstances, membranes of the ventricular cells are loading cations into the ventricular cell. When more and more cations are loaded, then resting membrane potential cannot really rest, and cationic load will produce fluctuations in resting membrane potential, and if such fluctuating resting membrane potential touches the threshold, it may produce unwanted triggered automatic events, and that may precipitate tachyarrhythmia. The third mechanism of tachyarrhythmia is re-entry or circus movement. Now let me explain how re-entry can produce the problem. Let's suppose this is a piece of myocardium, right? This is a piece of myocardium, and let's suppose there is some area which is electrically not excitable. For example, this is a scar in myocardium, right? And it is electrically not excitable. Now listen carefully. If an electrical stimulus comes and it starts moving around this electrically resistant area, right? When it will move around, if they meet each other at the same time, then they cannot re-enter, they have to move forward. So in this particular example, we see that electrical impulse has approached an scarred area in the heart, and it went around that from the both sides, but because conduction velocity on both sides was same, so impulse reaches to other side of the area at the same time, and these impulses cannot re-enter into each other area because every area is refractory, and this impulse has to move forward. Now, if suppose we take another example, this is another area in the heart and it is having scar, and electrical current comes to this area. On one side it moves well, and from other side it cannot move, there is a block, right? Now the limb, the side on which it moves slowly, when it will come back, it will find this area excitable, and if this point comes out and finds this area excitable, then this current will enter into the area back, and then this current may start moving around this dead area, and this type of situation is specially seen when total time taken by a cardiac impulse around an area is longer than the time required for a blocked area to recover from the refractory phase and become excitable. Again, let me tell you that if cardiac impulse moves around a dead area or electrically dead area, then when impulse is moving around the dead area and total time taken to move in the circle is longer than the time for any block in the tissue to come out of the refractory area, then it will start moving rapidly. And if this start moving around that area rapidly, this is called circus movement. It will keep on throwing cardiac impulses with every circle to the rest of the heart, and tachyarrhythmias will be generated. This is one of the mechanisms how tachyarrhythmias are generated in patients with ischemic heart disease. Again, let me recap how the tachyarrhythmias can be produced. Tachyarrhythmias can be produced when normal automaticity is enhanced, like catecholamine stimulates SC node. When tachyarrhythmia can be produced when triggered automaticity is there, for example, ischemic cells in the ventricular area and ischemic cells have loaded lot of cations, and then their resting membrane potential become very near to the threshold, and anytime they can produce triggered depolarizations. Then another mechanism is when in the myocardium there is some area through which current cannot conduct, and current moves around that area, and if there's a long time for the current to move around that area, right, and during this time that every point is excitable, so circus movement will start and there will be excessive electrical stimulation of the heart. Now we will talk in detail sinus arrhythmia and ECG patterns, right? We'll talk about the sinus problems, sinus arrhythmias and ECG patterns. Sinus arrhythmias and ECG pattern. First of all, we will talk about physiological sinus arrhythmia. Physiological sinus arrhythmia. Physiological sinus arrhythmia is a normal phenomenon which happens with all the people with normal heart and normal neurological connections. What really happens, as you know, that heart is under the influence of autonomic nervous system, right? And one of the major parasympathetic outflow, which is called vagus, that controls the automaticity of SA node. From the medulla, this is the vagal outflow, and vagus stimulates the activity of, more accurately, vagus influences the activity of the SA node as well as AV node. Right now we'll concentrate the relationship between the vagus and SA node. Vagus is stimulating the final neurons which release acetylcholine on the SA node. So vagus has inhibitory influence on SA node. It means whenever vagus is stimulated, right, SA node will be inhibited and heart rate will go down. And whenever vagus is itself inhibited, when vagus is not working, heart rate will go up. Now, a very important concept to understand is that vagal activity fluctuates during respiratory cycle. During expiration, suppose here is inspiration and here is expiration. During inspiratory phase, vagus is inhibited. It means during inspiration, if vagus is inhibited, it means heart is released from vagal inhibitory action and heart rate will go up. But during expiration, vagus is stimulated. Because during expiration, vagal outflow is stimulated, so it means during expiration, through the vagus, SA node will be inhibited. So what does it mean? That during inspiration, your heart rate will go slightly up, and during expiration, your heart rate will go slightly down, right? And this is normal and physiological. So we can recap all this information that during respiratory cycle, vagal outflow alters. And when vagal outflow alters, then SA node automaticity alters, and that changes the heart rate. During inspiration, vagus is inhibited. Once vagus is inhibited, then vagus cannot inhibit SA node and heart rate goes up. So this is a slight increase in heart rate during inspiration. But as soon as you start expiration, vagus is stimulated, it is able to inhibit the heart rate. So during expiration, your heart rate goes slightly down. This phenomenon is called physiological sinus arrhythmia, right? And here's a small clinical point that patient who have autonomic neuropathy, for example, the people with diabetes mellitus, if vagus is not working, right, what will happen? That their heart rate will not fluctuate with the inspiratory and expiratory system. Again, let me repeat it, that due to any reason, if vagus is unable to influence the heart, for example, in diabetic patient, if there is autonomic neuropathy, and during the autonomic neuropathy, if vagus is not functional, one of the complications will be that heart rate will not fluctuate during the respiratory cycle, right? In the same way, one more piece of information is that during the heart plant, patient who has transplanted heart, right? Transplanted heart is a denervated heart and it is not connected with the vagus. So transplanted heart is not under vagal influence. And if transplanted heart is not under vagal influence, it means that transplanted heart will not undergo physiological sinus arrhythmia, right? The heart rate of a patient having a transplanted heart will remain same during the respiratory cycle, right? Now, let's draw the ECG of physiological sinus arrhythmia. Let's suppose first I draw the ECG, P wave, QRST, P wave, QRST. Of course, again next cycle P wave, QRST, P wave, QRST, P wave, QRST. Now I have drawn some patterns over here. What I really want to tell you that during inspiration, this distance, this is R wave, this is also R wave, and this distance is called R to R distance. Now, during inspiratory during inspiration heart rate goes up. It means during inspiration R to R distance will decrease. In a given time, there will be more P waves and more QRS complexes. It means that during inspiration in a normal person's heart, if you look at the ECG recorded during inspiratory event, R to R distance will decrease. In a smaller time, there will be more complexes. But during expiration, when vagal influence becomes more and heart rate goes down, so during expiration, R to R distance will become more, right? So again, if you look at the ECG and R to R distance regularly becomes shorter, right? That must be during the inspiration, and it becomes regularly slightly increased, that will become expiratory system, right? After this, physiological sinus arrhythmia, now we'll talk about one more event. Let's suppose we talk about sinus tachycardia. Sinus tachycardia. What is meant by sinus tachycardia? First of all, you must know what is meant by tachycardia. We have already discussed tachycardia means heart rate is more than 100. When we say patient has sinus tachycardia, it means that heart rate which is more than 100 is due to increased activity in the sinus, increased activity in the SA node, right? Sinus tachycardia very commonly seen during exercise. Exercise increases your heart rate, or patient with fever, or patient with thyrotoxicosis, right? And there are many other conditions which increase the heart rate. And in these conditions like exercise or fever or thyrotoxicosis, there is overstimulation of SA node. And when stimulation of SA node is there, excessive stimulation to SA node will generate depolarizations more frequently, and your heart rate will go up. Under these circumstances, what will happen? Look, this was the normal. Now, these were the P waves, and of course, these P waves are presenting atrial depolarization, which is of course occurring due to sinus activity. Now, if there is sinus tachycardia, what will really happen that SA node will be firing more frequently. It means that P waves will be produced more frequently in a given time. So what will happen? Look at the ECG of sinus tachycardia. Now P wave appears earlier, and if P waves appears earlier, then again P waves appears earlier. So due to increased activity of SA node, right, what is happening? Now you can see in the same given time the heart rate has been increased. As you can see it that here when the heart rate was normal, and in this given time there were 1, 2, 3, 4, 5, 6 sinus activities. And but if you look at this situation where there is sinus tachycardia, we find 1, 2, 3, 4, 5, 6, 7, 8 and 9 P waves, of course followed by the QRST complexes. So what really we see that in this black pattern we find the normal sinus activity, right? And in this red pattern we find that there is sinus tachycardia because P waves are appearing earlier in the time, SA node is firing at a faster pace. So in a same given time, in this particular case, we have more cardiac stimulations. So heart rate increases. Now we can take another example that let's suppose there is another patient who has sinus bradycardia, sinus bradycardia. It means this patient has slow heart rate. Bradycardia means slow heart rate. But the origin of slowness is problem with the sinus, problem with the SA node. That there is something which is inhibiting the SA node, so heart rate is less than 60 per minute, right? Classical example may be, yes, athletes. You know why some athletes, the heart rate is very slow, right? The reason being that they have increased vagal tone, right? Then we can talk about patients with hypothyroidism. When you have hypothyroidism, then your heart rate becomes slow. Or patient with hypothermia, right? Their heart rate becomes slow. Or patient with obstructive jaundice, cholestatic jaundice. In these cases, retained bile acid accumulate in SA node and slow down the activity of SA node. So whatever the reason, if there is anything which is pathologically slowing the SA node automaticity, then naturally when you look at the ECG pattern, you will be able to find the evidence of bradycardia. Let's suppose in this particular case where the sinus bradycardia, ECG pattern will be, let me show it by blue, that P waves are appearing less frequently. So here's a long pause, then there is P followed by QRST. Then again there is a long pause, then there is P wave and QRST. Again there is a long pause, P wave followed by QRST. Now what we really see that here P waves are appearing with lesser frequency in the same given time in which normal person was producing 6 P waves, person with tachycardia during the same time was producing how many P waves? 9 P waves, and this person during the same time is producing just 4 or at the maximum maybe 5th wave. So what we really see that in case of sinus tachycardia, RR distance will become less, but in case of sinus bradycardia, RR distance will become more. Or again, but remember when we talk about sinus tachycardia or sinus bradycardia, the electrical activity which is increased or decreased, that is originating from sinus tissue, right? Then we will come to one more condition. In that condition, there is SA node is injured and it behaves in an irregular fashion. Suddenly sinus activity become increased and then sinus activity become slower than normal. If it is happening like this, that you have a disease and SA node is infarcted partially or injured partially, and suddenly it becomes fast, and then it becomes suddenly slow. So we can say you have a funny type of syndrome which is called Tachycardia syndrome. That is sinus syndrome, sinus Tachycardia syndrome, or an easier way to remember this is that sick sinus syndrome, S-I-C-K, sick sinus syndrome. So in this sick sinus syndrome, what really happens that SI node is behaving in a pathological fashion. For some time, it may be firing faster than the normal, and at other times, it may be firing slower than normal pace. For example, that in Tachycardia syndrome, maybe SI node is first firing more frequently, and P waves are appearing very, very early in the time, and then SI node suddenly start firing at a slower pace. So then of course heart rate for that very piece of time will be less than normal. So we can say this is a patient, he is having Tachycardia syndrome, or simply we can call this patient has sick sinus syndrome. Again, let's recap. We were now concentrating on sinus arrhythmias. But whenever we talk about sinus arrhythmias, we must remember that even a normal person has physiological sinus arrhythmia, which is very mild, and this physiological sinus arrhythmia is due to vagal tone fluctuations during respiratory cycle. Then there is sinus tachycardia, in which SI node overdrives the heart. Then there is sinus bradycardia, where SI node is underdriving the heart. Then there is sick sinus syndrome, where SI node sometimes overdrives the heart and then underdrives the heart. Now we will be discussing atrial abnormal rhythms and ECG. Atrial tachyarrhythmias, arrhythmias, and ECG. Now when we talk about the atrial tachyarrhythmias, basically there are three types. There is atrial tachycardia, atrial tachycardias, atrial flutters, flutter, and atrial fibrillation. Now, in atrial tachycardia, what really happens that P waves or atrial activity is, atria is acting as pacemaker, and it is producing electrical activity at the rate of somewhere between 120 to 250. So atrial tachycardia, the electrical activity rate is somewhere between 120 to 250 per minute. In atrial flutter, the electrical activity is somewhere between 250 to 350. And we have already discussed that in atrial fibrillation, electrical activity in the atria is more than, it is more than 350. Now, when you look at the ECG pattern, all these things are produced when atria is abnormally irritated or there is re-entry phenomenon. Now, if you look at the ECG pattern, what really happens in atrial tachycardias, you can see some P waves, but you find well-defined multiple P waves, right? And after those P waves, you may find QRST complex. It means if there were 3 P waves, right? But only one could be conducted down the AV node, and it was able to produce depolarization of ventricle and eventually repolarization. Then again you find multiple P waves, and they may be followed again by one QRST, and this pattern may be repeated many times like this. So what we really see that atrial rate is where atrial electrical activity is very fast as compared to the ventricular electrical activity. Again, you know, these P waves which are well defined, but they multiple, so multiple P waves are followed by QRST complex. So it means the multiple atrial activity which is followed by one, yes, ventricular electrical activity, right? Now, in case of atrial flutters, what really happens that electrical activity in the atrium become really very fast in case of atrial flutter. So in this case, what you really see are special type of waves, and they are not well recognized P waves, right? And then there may be QRST complex, and after that again sawtooth like P waves, and followed by, they should not be really called P waves, they are called actually flutter waves, so we call them F waves. So flutter waves are a sawtooth like shaped, you can say, pattern drawn by the very rapid depolarizations present in the atrial tissue, right? And then again this is followed by QRST. So these are flutter waves, right? Now these are flutter waves. But when we talk about atrial fibrillation, it means there is a very fast rhythm in the atrium, right? And in this particular case, when we say that there is flutter, there is fibrillation, it means there is more than one ectopic foci. They are simultaneously firing, and due to so many irritable foci which are trying to take control of the atrial activity simultaneously, there may be multiple vectors present in the depolarization vector present in atrium, and these vectors are directed in different directions at a given time, and so these vectors are very small, and these electrical activity which are from multiple sources, and they are producing small vectors which are directed against each other. They are not synchronized, these are dissynchronized. So due to that reason, there is no well-defined electrical power in the, or well-defined electrical vector in the atrial area. Due to that reason, now you will find that baseline which should show P waves, right? This baseline just shows some fluctuations, and these fluctuations are showing that there are small electrical activities, but many of them present in atrium. Then eventually one electrical activity will be conducted down through AV node, and that will produce QRST complex. But again, there may be slight fluctuation at the baseline, and then again QRST will be there, right? And this pattern will be repeated again and again, right? So this type of ECG is typically seen when there is atrial fibrillation, and these small waves are called F wave. But remember, flutter F waves are shown by the capital letter, and fibrillation F waves are shown by the small letter. Now again, let me repeat it. When there is abnormal electrical activity in the atrium, it may lead to atrial tachycardia, or it may lead to atrial flutters or atrial fibrillation. In this case, electrical activity in the atrium is progressively increasing. In case of atrial tachycardia, there are multiple well-defined recognizable P waves followed by QRST complex, right? In case of atrial flutter, there are not well-defined P waves, rather we see that there are sawtooth-like baseline fluctuations, and we call them flutter waves, right? And in case of atrial fibrillation, the fibrillation waves are multiple, very small. They must show slight oscillation in the baseline and occasionally punctuated by QRST complexes. Again, one point which is very important is when a patient is suffering with atrial tachyarrhythmia, we have to be very careful that these tachyarrhythmias should not transmit rapidly to the ventricles, because if atrial tachyarrhythmia rapidly transfer to the ventricle, then they can precipitate ventricular tachyarrhythmias, which may be life-threatening. Dangerous aspect related with the atrial tachyarrhythmia is that if AV node is highly excitable, it takes too many impulses from the atria to the ventricles. And if AV node is conducting too many impulses, electrical impulses from the atria to the ventricles, that may overdrive the ventricles, and under these circumstances, atrial tachyarrhythmias may precipitate ventricular tachyarrhythmias, which may be life-threatening, right? So, what we really do in the management of these patients, ideally speaking, we must terminate the atrial tachyarrhythmias. But if we cannot terminate the atrial tachyarrhythmias, then we should slow down the AV node, because if we slow down the AV node in these patients, even if fast electrical activity continues in the upper story, but if AV node is really slow, it will allow lesser impulses and controlled transfer of cardiac impulses from the atrium to the ventricle, and we will not have the risk of precipitation of ventricular tachyarrhythmias. I think all of you must be knowing the drugs which are commonly used to slow down the AV node, right? These drugs which slow down the AV node, of course, they are calcium channel blockers, they are beta blockers, calcium channel blockers like verapamil, beta blockers like propranolol, or these drugs may be digitalis. You know, digitalis everyone knows that digitalis is positive inotropic drug and which is used in cardiac failure, but very good doctors know that digitalis can also increase the vagal activity. It's a vagotonic drug, and when vagal activity is increased, AV node is slowed down, so too much impulses from the atrial area cannot go down into ventricular area, right? So digitalis here is used as a vagotonic drug. Then sometimes to really slow down the AV node for a very short. Now we have already discussed about the sinus arrhythmias, right? We have already discussed in previous lecture about the atrial arrhythmia. Now we'll concentrate the rhythm problems around the junction, the rhythm problems at the around AV nodal area. The point which is very important to understand first of all is that the fibrous area, right? This green area is representing the fibrous area, fibrous ring, and atria are mounted above this ring and ventricles are mounted below this ring. And this green area or fibrous area act as insulator. It acts as an electrical insulator. Because this green area acts as an electrical insulator, so current cannot pass through this green area. It means the only area through which current can pass from the atria to the ventricle, the only area is AV node. So we can say AV node is a specialized electrical window or specialized electrical connection between the atria and the ventricular system, right? In a normal heart, there is only one electrical passage, that is AV node and bundle of hairs from the atria to the ventricle. As we have discussed previously, that atrial depolarization will lead to atrial contraction, right? Atrial electrical activity will lead to atrial mechanical activity. And you know mechanical activity is slow. So when atria are contracting and pushing the blood into ventricles, the current is held for a while in AV node. AV node is a tissue which is specialized in slow conduction. AV node is a tissue which is specialized in slow conduction. As I told you previously that SA node is specialized in high automaticity. Atrial and ventricular muscle is specialized in contraction. AV node is specialized in slow conduction, and bundle of hairs, and what is this? Bundle branches and Purkinje system, this is specialized in fast conduction. So one of the very important function of AV node is that it will conduct the current from atria to ventricle with extremely slow velocity. It means when current enters in the AV node and when it exits from the AV node, there is a delay about 0.1 second. This delay is very, very important for the mechanical function of the heart. What is the importance of this AV nodal delay? The importance of this delay is that it allows the atria to comfortably empty their blood into ventricles. Only when atria have completed their systole, only then current from the AV node is released into ventricle and then ventricular systole start. Is it clear to everyone? Now, sometimes what happens that at this junction there is a problem. Either this junctional tissue becomes too fast, then we say they are junctional tachyarrhythmias, or junctional tissue becomes too slow, then we call it junctional bradyarrhythmia. Is that right? Now, first I will explain that why AV node is a slow conductor. First I will explain why the AV node is slow conductor, and then I will tell you what are the different pathological conditions which make the slow tissue deadly slow and which may be a problem for us, right? So let's suppose that this is the AV nodal tissue. I've enlarged it, this bundle of hairs. The current has to enter from this point and it has to, yes, exit at this point to the bundle of hairs and ventricular system. Now, I said current passes through this extremely slowly. Why? What is the reason for that? One reason is, there are multiple reasons. One reason is that AV nodal cells are very small in size. They are not large cells, they are small cells. Opposite to that, and when there are very small cells, it means current has to jump many membranes in a short distance. AV node is full of very small cells. These are not large cells. AV nodal cells are specialized myocardial cells which are very small. Number one, small cells. Number two, that in between the AV nodal cells, gap junctions are very few. You know, gap junctions are the specialized area in between the myocardial cell which help the transfer of the current from one cell to the next cell. You can say gap junctions are electrical windows between the different myocardial cells. These electrical windows through which the current can jump from one cell to the next cell, these are very few in AV nodal tissue. So, few gap junctions. What are gap junctions? Gap junctions are specialized connections in between the myocardial cells through which current can pass from one cell to the next cell, and for electrical current passage or cationic current passage, this is low resistance area. For AV node, within the AV node, in between the cells, such gap junctions are very few. So current will go extremely slowly, right? This is second reason. Third reason why AV nodal current flow is slow is the diameter of the cell is thin. So not only size of the cell is small, rather diameter is also smaller. Diameter of cell. You know, the cells with smaller diameter, they conduct slowly. They offer more resistance to the current. And cell with larger diameter, they offer less resistance. And number four, which is the most important point, if you forget all of them, you should not forget the last one. I put the most important in the end and put a star with it. The one of the most important reason why AV node is so slow is that if I draw one AV nodal cell larger, that AV nodal cell has resting membrane potential of minus 60 millivolt. And at the resting membrane potential of minus 60 millivolt, right, the fast conducting sodium channels are permanently closed. There are, for depolarizing current, there can be two types of channel. Number one, voltage gated sodium channel. Other can be voltage gated calcium channels. At minus 60 millivolt, voltage gated sodium channels become permanently dysfunctional, inactivated. So in the SA node and AV node, voltage gated sodium channels are not functional. That is why SA node and AV node depend on voltage gated calcium channels for their depolarization. Is that right? So SC nodal and AV nodal depolarization is calcium dependent, and as compared to voltage gated sodium channels, voltage gated calcium channels act slowly. So that is one reason that depolarization is slow in SC node and AV node. Second reason is that, when cations have to move in, if inside, just hypothetically I'm talking about, if due to any reason, if this cell has a resting magnetic potential of minus 90 millivolt, what do you think? If cell has minus 60 or cell has minus 90, right? This is condition number A and this is condition number B. What do you think, in which condition current will very rapidly jump in, cationic current, at minus 60 or minus 90? At minus 90, because there is more electronegativity. And again, AV nodal cells have resting magnetic potential of minus 60. They do not have resting magnetic potential of minus 90. It means they cannot cause the fast influx of cations because the electronegativity in the AV nodal cell is less negative. So it attracts the cations slowly. So naturally, current has to move. It's cationic current, right? It has to move fastly or slowly? Slowly. Opposite to that, because these electrical properties, so we can say that resting membrane potential of AV node is minus 60 millivolt. It also keeps the AV nodal system slow conductor. But if you compare the bundle of hairs, this bundle of hairs or bundle branches or their small branches which are called Purkinje fibers, all of these are specialized in fast conduction. Bundle of hairs, bundle branches, Purkinje fibers, all of them are made of special type of cells. Bundle of hairs is a special type of cell, bundle branches are special cells, Purkinje system has special cells. These specialized cells and tissue is having specialization in fast conduction, right? AV node was specialist in slow conduction, and tissue AV and remaining tissue, conducting tissue, is specialized in fast conduction. Is that right? And this tissue, bundle of hairs, bundle branches, and Purkinje system, they are made of specialized cells. These cells are called Purkinje cell. Many students confuse the Purkinje cell and Purkinje fiber. Again, let me repeat it. AV node is specialized in slow conduction. Here is what? Bundle of hairs, bundle branches. Now, bundle of hairs is made of special cells, and these cells are called Purkinje cells. These branches are also made of specialized cells. These cells are also Purkinje fibers. Even these branches, and from their branches come out, all of these are made of which type of cells? Purkinje cells. So what we can say, that bundle of hairs, bundle branches, and Purkinje fibers, all of them are made of specialized myocardial cells, right? And these specialized myocardial cells are specialists in conducting slow or fast? Fast conductor, right? These cells are called Purkinje cells. But out of these, when small branches come out, these are called Purkinje fiber. Now, I have to tell you why current passes rapidly through Purkinje system. Why current passes rapidly through Purkinje system or bundle branches. For this explanation, let's compare the fast conducting tissue, right, from here up to here. Now, in fast conducting tissue, number one, the cells are larger. Number two, cells are oriented along the current flow. Look, in AV node, cells are smaller. Their cells are, this is slow conductor, specialist in slow conduction. This is Purkinje system, specialist in fast conduction. This is specialist in fast conduction. Here the cells are smaller, there the cells are, yes, larger cells, right? Number two, here the cells are oriented perpendicular to the current flow, against the current flow. Here the cells are oriented along the axis of Cell is along the current flow. Here gap junctions were less. Here the gap junctions are just place more. The more gap junctions, electrical windows through which current can jump from one cell to the next cells. So more gap junctions. Then of course these cells were having less diameter. So more resistance. If you have a narrow tube, water will have more resistance. Your wide tube, water has less resistance to pass. Same is true about the electrical current. Through this wider diameter cells, current passes more efficiently. So one more reason why this tissue is fast conductor is that more diameter of cells. Diameter of cells. And now one of the most important reason I'm putting that these cells have resting membrane potential of minus 90 millivolt. Right? This factor also make it a fast conductor, that its resting membrane potential is minus 90 millivolt. Why it is so? Why it is so? It's very easy to understand. The reason being, when it is minus 90 millivolt, then voltage gated sodium channel can be functional. So these are fast conducting channels. Number two, when cations have to jump in, there's too much electronegativity inside which very briskly attract the cations from outside to inside. So depolarizations are rapid. Right? So due to this reason, we can say that our junctional tissue is specialized in slow conduction, and beyond the junctional tissue, the Purkinje system is specialized in fast conduction. Having said this basic concept, now we come to that how the junctional bradycardias are produced. In the previous lecture, we discussed about the vectorial analysis of electrical activity in the heart. Right? I will just repeat a little bit. That when in the heart we do the vectorial analysis of electrical activity. Vectorial analysis means that electromagnetic forces in the heart which they are produced due to electrical current, they are presented as vector. Now look, the vector for atrial depolarization was a small vector directed downward and leftward. We have discussed it previously, right? Then we discussed that when current passes through AV node, it is a very small tissue which undergoes depolarization very slowly. So until the current is held at this point within the AV node, our ECG machine cannot pick up this so small electrical activity. So needle will not fluctuate and it will make a straight segment. Is that right? After that, I told you that there is ventricular depolarization. First there is septal ventricular depolarization, which is directed upward and rightward. Then I told you there is major ventricular depolarization, which is directed downward and leftward, and in the end I told you basal ventricular depolarization. Now, when we make ECG pattern according to these vectors, just a little revision, that let's suppose this is the person is a little bit asymmetric. Now, here is our ECG machine. We put positive electrode here, let's suppose limb lead number 2, and we put a negative electrode here on right arm. Now this is the axis of the lead. When we draw the ECG, until there is no electrical activity, it will draw a straight line. As soon as atrial depolarization will start, atrial vector is moving towards positive electrode. So deflection should be positive. And with fast or moderate or slow? Now, atrial tissue undergoes depolarization with moderate velocity. AV node undergoes depolarization very slowly. Purkinje system undergoes depolarization very fastly. So you have to remember it. So it means when atrial depolarization is going on, it means a small vector is moving towards the positive electrode. So deflection of the needle will be to the positive side, but because it is moving with moderate speed, so needle will deflect with moderate velocity up and then down. So that will produce a wave like this, which is atrial depolarization wave called P wave, right? Then once atria has completed its depolarization, now current is held in AV node. Current is passing through AV node very slowly. As I told you previously, when current is passing through the AV node, it is undergoing deposition so slowly and tissue is so small that it won't influence the needle. So until current is stuck into AV node, will needle fluctuate? No. And if needle is not fluctuating, for that much duration for which current is held in AV node, it will draw, yes, straight line. You must remember that there was a paper here, which was paper rule, which was moving in this direction, right, under this pointer. Now, this is the segment, and until current remain in AV node, this segment, straight segment will be drawn. But as soon as current current exit from AV node and enter into fast conduction system, ventricular depolarization will start. As soon as ventricular depolarization starts, I told you ventricular depolarization is in 3 steps. Ventricular septal depolarization, where septum is depolarized rightward and upward. So this vector, and all the ventricular depolarizations are fast. So this vector is a fast vector, even though small vector, but fast vector. This is major ventricular depolarization vector, it is also a fast vector. This is basal ventricular depolarization, it is also a fast vector. So ventricular depolarization, which is done in 3 steps: septal depolarization, major ventricular depolarization, basal ventricular depolarization. All these ventricular depolarizations are, now you are supposed to tell me these are slow or with moderate speed or fast speed. So whatever needle fluctuation will be, it will be slow fluctuation or fast fluctuation? Fast fluctuation. Now you see, this vector is moving towards the positive electrode or away? Away. So deflection has to be negative. Small vector, so a small negative deflection. After that, major ventricular depolarization start. Current start moving from in to out. Depolarization current. A very big electromagnetic force is moving towards positive electrode. A very big electromagnetic force is moving towards the positive electrode. There will be a very powerful negative deflection or positive deflection. Positive deflection. And slow deflection or fast deflection? Fast deflection. So it will move like that. And of course, the last part of the ventricle which undergoes depolarization is basal part of ventricular depolarization, and this is moving away from the positive electrode, and that will produce what? Another negative deflection. And until ventricle remain completely depolarized, needle will not fluctuate, it will again draw a straight line, and eventually ventricular repolarization will start. And I've explained in previous lecture that when ventricular repolarization starts, repolarization current from move out to inward, and it is movement of electropositivity, electronegativity. Repolarization, electronegativity. Depolarization is movement of electropositivity. When we say tissue is depolarized, it means tissue is becoming electropositive. Sodium influx occur or calcium influx occur depending upon the tissue. So when there is repolarization, the interior of the cell membrane is re-establishing their electronegativity, right? So during repolarization, current is moving from outside to inward, and when current is moving like this, right, a vector is made in this direction, but this is not electropositivity, this is electronegativity. Now you see electronegativity moving towards electronegativity. Deflection should be positive. The rule is this: positive moving towards positive, deflection positive; negative moving towards negative, deflection positive. But if positive moving away from positive, deflection will be negative. So there will be positive deflection and ventricular repolarization. And repolarization is a fast phenomenon or slow phenomenon or moderate? It's moderate. Repolarization is moderate. It's not fast, because repolarization occurs with moderate velocity. So this needle will go positively with moderate velocity and come down. So it will make again a repolarizing wave, and this is T wave. Is that right? Of course, this was QRS, responsible for spread of depolarization through the ventricle. Now, out of all this thing, right now we'll concentrate on this point. Right? This straight isoelectric segment, right, in which needle does not move, this represents the AV nodal delay, right? And this is called, the segment is called, who will tell me, what is the name of the segment? Yes, PR or PQ? It should be ideally called PQ, but actually we call it PR. Why we call it PR? Because in most of the leads, Q wave is absent. In most of the leads, Q wave is absent. So that is why it is called PR segment. But actually, if Q wave is present, then the segment should be terminated as soon as Q wave start, right? So it is classically called PR segment. So PR segment is the duration for which the current is held in AV node. And sometimes we measure the onset of electrical activity from SC node, atrial depolarization, until the current start in ventricular tissue, right? In those circumstances, it has to be that long. It includes the P wave plus PR segment, and this is called, yes, PR, what is it called? Interval. So PR interval represents atrial depolarization plus AV nodal delay, and PR segment represents just AV nodal delay. Is that right? Now, as we start talking about junctional tachyarrhythmias or bradyarrhythmias, the point which we have to correlate is that if anything which makes the AV node more slow, then the segment will become longer. And whenever PR segment will become long, for example, you give me a drug, and AV node hold the current not for 0.1 second, AV node holds the current for 0.2 second. It means it is holding the current for unusually long time. If AV node is holding the current for unusually long time, needle will not fluctuate, and this isoelectric line will be longer than our expectations. We say PR segment is elongated, but more commonly we use the term that PR interval is elongated. It's very easy to understand that whenever PR segment is prolonged, automatically PR interval will be also prolonged. Am I clear? In the same way, if you take some drug or some substance which is increasing the conduction through AV node, if conduction through AV node is fast, then it means current will jump from atria to the ventricular rapidly. So this segment will become short. Can you tell me something which can enhance the conductivity of AV node? Anything in your mind which can increase the conductivity through AV node? Anything commonly we drink? Tell me. Caffeine. Heavy amount of caffeine, right? That can conduct the current more rapidly through AV node. Is that right? You know, caffeine goes inside the cell and inhibit phosphodiesterase enzyme, so cyclic AMP cannot break down, so intracellular cyclic AMP goes up, so protein kinase A activities goes up, phosphorylation of calcium channels become more, and tissue receive too much cations and conduction become fast. Is that right? So what really happens that when you take too much caffeine or you take any drug which is stimulant to AV node, of course all the drugs which are sympathomimetic, right? Whenever AV node is conduction is increased, current will jump from atria to ventricle more efficiently and PR segment will become less, but more commonly we say PR interval is shortened. Is that clear? Now after that, once you have the clear concept of what is PR segment and what is PR interval, and if you are very clear about this thing, that whenever PR segment varies, invariably lead to variation in PR interval. Is that right? Now we will go to concept of junctional bradycardias. Now, when we will talk about the junctional bradycardia, we also call them more commonly junctional blocks. The term which is more commonly used is junctional blocks. There are three terms for the same thing. When current through AV node is not passing efficiently, when current through AV node is delayed unusually, because normally it is delayed, unusually delayed, or it is unusually stuck up into AV node, then we use the terms. There are three terms which are used under these circumstances. Some people say junctional blocks. Junctional blocks. The other people, they will call it nodal blocks. Nodal blocks. And world is full of so many different type of people, and you may come across the people who simply call them heart blocks. Heart blocks. So this is one and the same thing. Junctional blocks or nodal blocks or heart block, concept of these blocks mean that there is unusual block to the electrical activity when it is trying to pass from atria to the ventricle. There is unusual degree of block present over there. Is that right? So we will talk about these junctional blocks now. Let's suppose if I make an AV node here, suppose this is an AV node. Normally what happens, now first you concentrate on the normal thing. Normally what happens, current comes, it is delayed here for how much time? 0.1 second, and then it will exit. The next wave will come, that is also delayed for same time, and it will exit. Next wave will come, delayed for the same time, and exit. This is what is normally happening, right? And if I draw the ECG pattern of this, so naturally this is P wave, P wave, P wave, and this will be QRS. So you see, in this particular example, every P wave is followed by QRS. First P wave, second P wave, third P wave. In this activity, what I'm showing that there were three P waves which approached AV node. When first approached, with some delay, it converted into QRS. Same happened with the second and third. If I draw the ECG of this type of system, P wave, QRST, then P wave, QRST, then third P wave and QRST. The point which I want to show that all of them have almost same length of PR interval. All of them have same length of PR interval because the delay through AV node is same in all cases. This is the delay. Is that right? Now, let's suppose that I give you a drug which slows down the AV node. Can you tell me a drug which can slow down the AV node? Beta blocker, excellent. Calcium channel blockers. And if you really want to shut down the AV node, adenosine or digitalis can give vagotonic influence and slow down the AV node. Right now we talk about, let's suppose, calcium channel blocker. You give a little dose of calcium channel blocker and you slow down the AV node little more than normal. What will happen to this person? Now I'll draw another diagram. Here atrial activity will come, but it will be unusually delayed. It should have traveled from here down, but it was unduly delayed, but eventually it exit. The next wave came, it also unusually delayed, then it exit. Next wave came, unusually delayed, but then it came to ventricles. It means every atrial activity was conducted to ventricle. Every P was followed by QRS. But there was a problem. What was the problem? That there was unusually long delay in AV node. Due to that reason, ECG will change a little bit. And what will be the change? PR interval will be elongated, right? For example, if I draw the ECG pattern of this situation, right? In this case, every P is followed by QRS, but current was held in AV node with unusually longer time because calcium channels were, some of the calcium channels were blocked. So conduction was very, very slow. Now in this case, what I will do, this is P, but this is prolonged. The AV nodal duration is prolonged. And of course it was followed by QRST. Then there was next P, again it was prolonged, QRST. Then there was next P and too much prolonged and QRST. Now in these examples, every P was followed by QRS. It means every atrial activity was followed by ventricular activity, but there was undue delay. And here PR interval is prolonged. Now this type of block is called first degree block. This is a very mild block. Every current from atrium is allowed to go to the ventricle, but it is held in the AV node for unusually longer duration. So we say that here there was prolonged delay, and we will say that there is pathological prolongation of PR interval, and this type of problem is called first degree heart block, or first degree nodal block, or first degree junctional block, right? Now let's compare the first degree problem with the second degree problem. Now in the same patient, if you increase the dose of beta blocker, it means you are further suppressing the conduction through AV node. If you further suppress it, now look at this situation. This P wave come, atrial depolarization come, it was held for some time there and it could exit. But when the next came, it could never exit. It means this P will not be followed by QRS. And next came and it was held and eventually exit. So the real problem is here. What's wrong with this patient? Now, some of the atrial activity is conducted down and some of it is not conducted to ventricles. It means all the P waves are not followed by QRS, right? If I draw the ECG for this particular patient, okay, let me make the ECG of this particular patient. I will draw it here. P wave followed by, yes, QRST. This was the first pattern. Then P wave came, but here should have been QRS, but there is no QRS. So it means this were significantly blocked and it could not go down, right? And then it continued like this until the next P wave appear, and that P wave is followed by QRST. In this particular example, we say how many P waves are there? 3. But how many QRS complexes are there? 2. It means that out of 3 atrial, or out of some atrial activities, out of all atrial activities rather, some could conduct down and other could not, right? This type of block, which is more severe than the first block, this is called second degree heart block. So what is the difference in first degree and second degree heart block? In first degree heart block, every P is followed by QRS but with undue delay. And in second degree, some of the P are followed by QRS and some P waves are not followed by QRS. It means some atrial depolarizations are successfully transmitted to the ventricles and some of them are aborted within AV node. Is that right? Now, if you become really very bad with your patient, and of course you shouldn't do that, but if by mistake it happens, that you increase the dose of calcium channel blockers. It means you further suppress AV node. What will happen under those circumstances? Let's suppose we go to this patient. You have suppressed the AV node too much. You have suppressed too much. For example, you have given heavy dose of beta blockers, or you have given heavy dose of calcium channel blockers, or we do this thing by giving adenosine. For a very short time, adenosine is injected in vein. It blocks the AV node totally for a few seconds. Anyway, if you suppressed AV node too much, look here. Whatever P waves are coming, they are unable to follow. They are unable to go down. None of the atrial activity can pass to the ventricle. None of the atrial depolarization could pass to the ventricle. And under these circumstances, what will happen? You know, below the AV node there is bundle of hairs, and then there are bundle branches. Usually what happens, that when no current from atria can go to the ventricle, the new pacemaker develops somewhere here. Is that right? It means now atria will be driven by SA node. Atrium will be driven by SA node, and ventricle will be driven by a new pacemaker. It means atria are driven by a different pacemaker, which is physiological pacemaker, SA node, and ventricles are driven by another new pacemaker, because no current could come from the top to down, right? And this new pacemaker is of course not normal pacemaker. So it means the atria are paced at a different way, and ventricles are paced in a different way. Usually SA node may be driving the atrium at the rate of 80 beats per minute, and maybe this new, what is this? This new pacemaker may be producing depolarization just 40 beats per minute. So it means atrial electrical activity and mechanical activity will be 80 per minute, and ventricular electrical activity and mechanical activity will be dependent on the new pacemaker. If it is producing 40 currents per minute, then it will be 40 beats per minute. We say that now atrial and ventricular activity is dissociated from each other. Atrial and ventricular activity is no more synchronized. Usually every atrial current should be followed by ventricular activity. Here atrium are pacing independent of ventricular pacing system, and no current from the atrium, no current or cardiac impulse from the atrium can go to the ventricular system. We say there is a complete block or third degree block. The term which we use is third degree heart block, or another term is complete heart block. We call it complete nodal block, or complete junctional block, or complete heart block. Whenever we say there is complete heart block, it means none of the atrial electrical activity is transmitted to the ventricular system. Atria and ventricular are being paced by two different independent pacemakers. Am I clear to everyone? Right? And what will be the ECG? Here, should I draw the ECG for you, or you can make it in your mind that P waves are coming totally independent of QRS. P waves are appearing at the rate of 80 per minute, and QRS is appearing at the rate of 40 per minute. Is that right? So on the ECG pattern, you don't find there's any relationship between the P and QRS activity. Is that right? And this condition should be considered what block? Third degree heart block. So let's recap all of it rapidly. Junctional bradycardia, the classical examples are junctional blocks. When AV node is unduly suppressed, right, then current from atria to ventricle cannot pass in a normal fashion. If current from atria, every current from atria passes through ventricle, but with undue delay, we call it first degree. When some of the P waves can pass and other cannot pass, we call it second degree. When none of the P can conduct to ventricles and ventricle are going to have their own pacing activity. This is third degree heart block. Do you have any question about the heart blocks? A very basic concept. Now, we'll go in more detail of heart blocks. Look, first of all, concentrate on this ECG pattern. Right? First I will draw the normal so that you can compare it with others, with the normal one. Let's suppose this is the normal pattern. Now in this normal pattern, this is the PR interval and it's almost same everywhere, right? This is normal pattern. Now we come to first degree heart block. When we come to the first degree heart block, what's really there, that there's pathological prolongation of PR interval, that is more than 0.22 second PR interval. But the point which you have to remember here is that even though it is prolonged pathologically, but every P is followed by QRS. Every P is followed by QRS complex. It means all atrial activities have been conducted down into ventricle in spite of undue delay. So this will be first degree heart block. When we come to the second degree heart block, I told you previously that second degree heart block is defined that some of the P waves are conducted to the followed by QRS and other P waves are not followed by QRS. It means that in second degree heart block, some of the atrial impulses will go to the ventricles and others will not. But again it is subdivided into many types. I will tell you two important types. In Mobese 1, this is a very special type of, you can say, variety of heart block. What really happens, initially there is a P wave with normal delay, then next P wave is with undue delay, then next P wave is extremely undue delay followed by QRST, and then next P wave is not followed by QRS until now. Here is the big problem. Now look here, in this particular pattern, you concentrate. This is one PR interval, the next PR interval is longer than the previous one, and next PR interval is still very long. So there is progressive elongation of PR interval until one P wave is not followed by QRS, and then the cycle repeats, right? Again, Rahul, are you clear?
Yeah.
That in this particular it is type 2 because some of the P are conducted and other are not. But there is a very unique pattern. Then there is progressive elongation of PR interval until one P is not followed by QRS, right? This is called Mobese 1. This is called Mobese 1 pattern. In Mobese 2, what really happens that there is no variation in PR interval. It's simply, now look at this pattern and concentrate. Now here QRS has been missed. Now in this second pattern, if you concentrate, what you really see that PR interval is stable. right? But somewhere P wave may not be followed by QRS, and when P wave is not followed by QRS, it defines it as type 2 heart block. Is that right? But there is nothing like movies 1. What was the special aspect of uniqueness in the movies 1? There was progressive elongation of PR interval until one P was not followed by QRS. But if you concentrate on this, that PR interval is not progressively lengthening, rather it is stable until we come across a P wave which is not followed by QRS. And this type of variety is called movies type 2. This type of second degree heart block is called movies type 2. Then there is one more type of second degree heart block. In this particular case, this is one more type. Okay, some people will call it 2:1 block heart, 2:1 second degree heart block. In this case, what happened? That there are, after 2 P waves, one QRST is there, then P, another P, then QRST, then P, the P, then QRST. In this particular case, what you really see, that for every 2 P waves, there is one QRS. What does it mean? That out of 2 P waves, only one is conducted. Is that right? One is blocked, next is conducted. One is blocked, other is conductive. One is blocked, another is conductive. So it cannot be defined as movies 1 or movies 2. So they simply call it 2:1 second degree heart block. Is it clear? Can you differentiate these 3 cases? In case occasionally QRS is dropped, here also occasionally QRS is dropped, and here QRS is regularly dropped, right? Here before the P wave, before the QRS drop, there is progressive elongation of PR interval. Here before the QRS drop, there is no progressive elongation of PR intervals. Here out of every 2 P waves, one QRS is there, so it means for every other P wave, QRS is dropped. Is that right? And when we come to the third degree heart block, then naturally you know that on ECG there is no relation between P wave and QRS. This is T and this is P. They have appeared just after each other. Right? Now you see. Now look here. In this last pattern, this is third degree heart block. You see there is no relationship between P and QRS, which can be well defined. Look here. Here it looks as if after 2 P waves, there is one QRS. But you cannot, what you will say here? That there is no PR interval, just P wave came and immediately QRS came. It means that here when the SA node fire, just after, around that time, the pacemaker in the ventricle also fired, right? So first we feel depolarization finished in the atrium, and there was no current from atrium going to the ventricle. Ventricle had its own QRS complex, right? Again, here is P wave relationship, here is variable relationship. So P wave and QRS relationship is not stable here, and this condition is called third degree heart block. Any question you have here? No. So this was about the junctional bradycardias. Now we will talk about junctional tachycardias. Just few basic concepts. May I erase it? Now we will talk about junctional tachycardias. You know, junctional tachycardias, I don't know, some people really understand them fastly, and the other people who fail to understand them in spite of all effort. So, to avoid yourself being in the second category, try to use all the layers of your cerebral cortex when I explain. junctional tachycardias. Now, again your same diagram with the same specifications. This should be more near the endocardia. Now, what is the concept of junctional tachycardia? Junctional tachycardia means that there is something wrong at the junction. It means around or near the AV node. And there is some pathology here which is precipitating tachycardia. Now, how it really happens? Actually, one of the simplest example I can give you is that let's suppose you have a patient and he has abnormal connection between the atrium and ventricle. Now there are one connection or two connections? The one connection is AV nodal connection, other is pathological connection. This pathological connection is called bundle of Kent. What is it called? Bundle of Kent. Have you heard of it? K-E-N-T, right? Bundle of Kent. Some people are born with this anomaly. First we'll talk about the normal ECG and then we'll talk about why they undergo tachycardias at times. The normal ECG pattern is somewhat like this. When they are not in tachycardia, this wave is the pathological wave. Normally you expect it should go like this, then it should go like this, then it should go like this, right? But why it is turning like that? Is that right? Let me explain. Actually, if current is coming, let's suppose current is coming through this pathway and this is faster pathway. Current try to go from anomalous pathway as well as through normal, right? Now, when current will reach through the bundle of Kent here, before reaching to, look here please, this area, concentrate on this area. You know, this is a piece of myocardium which is connecting the bundle of Kent with the fast conduction pathway. Is that right? Right. Now, a bundle of His. Okay, we can make it like that. This is bundle of His. What really happens that because this pathway is faster than AV node, so this straight line becomes shorter. This straight line should have been from here to here, but actually this is short. Why this is short? Because as compared to AV node, this pathway takes the current rapidly. But when current comes from normal pathway, it rapidly enters into very fast conducting system directly. When current comes through AV nodal pathway, it directly enters into highway system, fast system. That is why that in normal person waves come. But here it is first entering into slow system in the muscle, not into Purkinje system, not into bundle of hairs. So between the bundle of Kent and between the fast conducting system, there is some myocardium which is conducting with moderate speed. Due to that reason, a small vector is made, and this vector, which is concerned with depolarization of some septal muscle, right? This vector which is made for the depolarization of some septal muscle, as current is moving from bundle of Kent to the fast conduction system, it produces a small vector which can lift the needle gradually up. And that is why this particular wave is going like this. But this is the moment. Look here, please. This is the moment when the current hits the fast conduction system, and then it very rapidly goes up and down. Is that right? Can you recognize this syndrome? You've heard of it. Excellent, excellent. So Rahul is not sleeping in the lecture. So he remembers it is Wolff-Parkinson's-White syndrome. Wolff-Parkinson's-White syndrome. So this is its classical ECG when tachycardia is not there, when junctional tachycardia is not there. But these patients, if they take coffee or they do some exercise, or they become emotionally excited, or they become worried, anxious, or they take alcohol, or they undergo any phenomenon which make the AV node fast, they precipitate dangerous tachyarrhythmias. Now let me tell you how they can precipitate dangerous junctional tachyarrhythmias. Look here. First, a basic concept. A SA node produces current after how much time? 0.8 second. If your heart rate is, let's suppose your heart rate is 72 per minute, it means the SA node is firing at the rate of 0.8 second. Every 0.8 second, SA node fires. And if every 0.8 second SA node is firing, it means every 0.8 second, of course, AV node will be releasing the current to ventricle. You know, if it fires after every 0.8 second, it means that how many, if 1 minute it is firing 72 times, how many times this will fire? It will also fire at the 72 times. Is that right? Now, let's imagine that you have taken, this patient has taken caffeine, and due to caffeine, he develops some irritable focus. Look here. He develops an irritable focus here. This star is showing an irritable focus, right? This is an irritable ectopic focus due to caffeine or due to some other sympathomimetic activity, and it produces an ectopic current. Now, listen here. It is producing an abnormal current, and this pathological current enter into what? Bundle of Kent. And it passes through bundle of Kent, it goes downward, as well as from here it re-enters. But when it re-enters, it finds that this area is again re-excitable, out of refractory period, and it starts rotating like this. If current start rotating here like this, if this rotation is taking 0.4 second, it means every 0.4 second one cycle will throw an impulse down. And if every 0.4 second one cycle is completed and an impulse is thrown down to the ventricles, it means heart rate will become double than 72, that is 144, and this will become tachycardia. Am I clear? Is it clear, or I should repeat it? Okay, let me tell you again. What really happens, normally, first understand normal. Normally when SA node is controlling the rhythm, when SA node fire, current may go down through both pathways, right? And by the time current reaches, try to re-enter, current was already coming from AV node as well. So can it re-enter? No. Because when current is passing through some area, that area is refractory for re-entry. That area is resistant to the phenomenon of re-entry. Again, let me repeat. When this person is not under tachycardia, why this person is normally not under tachycardia? The reason being, normally he is in sinus rhythm. When sinus rhythm is there, SA node is firing. When SA node is firing, SA nodal current goes to atria current, and atria gives impulse through bundle of Kent as well as impulse through AV node. And both impulses, wherever they meet, they cannot re-enter into each other's area. Is that right? So it is just like this, a car coming from here and car coming from here, they have to go down, both of them, they cannot re-enter into each other's area. Is that right? Now, if this person develops an irritable focus, and this irritable focus is very near to one of this pathway, either very near to this or very near to this. So it conducts only through one pathway and does not conduct through other pathway. Then the impulse which is going through one pathway, it may re-enter from the other pathway. And by the time it reaches back at the first point, if this point is still now has become out of refractory period and this point is excitable, re-entry will start. And we say that there is re-entrant tachycardia, or we say that there is circus movement, and this movement is completed within 0.4 second. Every 0.4 second, one shot is going down, and ventricles start beating, one ventricular beat every 0.4 second or every 0.3 second, and junctional tachycardia will start. Am I clear to you? Yes, Israel, you are clear? No problem? Or no problema? Okay. Another thing. Usually that is why for such patients, we say that they should avoid coffee, or they should avoid alcohol, or they should avoid smoking, or preferably if possible, they should avoid stresses of life. But I think this is not that easy, right? Anyway, so this was one example how junctional tachycardias are produced. One more example I would love to give you. And in that case, let's take another example of junctional tachycardia. In the second example, what we really see is that there is no bundle of Kent, there is no pathological connection, but within the AV node, listen carefully, within the AV node, two types of pathway are there. Right? Listen. That if someone has a problem within the AV node and one pathway conducts fastly, another pathway is conducting slowly, right? Then by chance, sometimes it's possible that current from the fast pathways goes down as well as it re-enter. We say intranodal re-entrant phenomenon. This is not intranodal because it is not within the node, right? But this is intranodal. There is no pathological connection. The defect is within the AV node, that within the AV node there are multiple pathways with different conduction velocities. So one pathway may be fast, other may be slow, and from one pathway when current is going down, it may re-enter through the other pathway. And if this is completing the cycle every 0.3 second, it will start shooting down the currents on the ventricles every 0.3 second, and heart rate will go to the around 180 or 200. Am I clear? So these were examples of junctional tachycardia. Again, how would you treat them? One of the classical method is massaging the, what is it? Carotid sinus. Because when you massage the carotid sinus, that will stimulate strong vagal outflow, right? And that may inhibit the AV node, and if AV node becomes too much inhibited, then naturally it cannot complete the cycle, and the re-entrant phenomenon will break down, and normal sinus rhythm may start again. For example, if you start massaging it, right, then vagus will inhibit this blue tissue, because this is under, AV node is under strong vagal control. When you massage here on the carotid sinus, as I told you, massage unilaterally, not both sides. Because if you massage on both sides, sometimes vagal outflow is so heavy that that may lead to cardiac arrest. So we massage on one side, and if there's a strong vagal impulse, AV node for a short time becomes too much inhibited. So current only passes through one pathway and cannot re-enter, it has to go down. And in this way, a circus movement is broken down, it's melted away. Is that right? Other method is we inject these patients with verapamil, intravenous verapamil, or we give any drug which can inhibit the AV node. Because in these treatment of this is that when there's junctional tachycardia, you have to slow the AV node so much that it becomes so refractory that it does not allow the movement of the circus to be completed. Is it clear? Any question here? No. Now, we have already discussed, yes, sinus arrhythmias. We have already discussed, yes, atrial arrhythmias, and thank God we have finished with the topic of nodal or junctional arrhythmias. Now we are entering into the last variety of arrhythmias, that is ventricular arrhythmias. Ventricular arrhythmias. To understand the concept of ventricular arrhythmias, especially ventricular tachyarrhythmia, first of all we should have a concept that why such tachyarrhythmias occur. One of the common cause of ventricular tachyarrhythmia are irritable foci in the ventricles. That is, sometimes in the ventricle, there are some cells which are highly irritable cells, and these irritable cells suddenly start firing in a pathological way. So we have to understand why some ventricular cells become highly irritable, right? Let's draw one ventricular cell here. Suppose this is a ventricular cell and I remove it out, and we will look for electrical activity in this cell. You must be knowing that normally, like all ventricular cells, this cell will be having resting membrane potential. Suppose the resting membrane potential is minus 90 millivolt in this cell, right? And threshold potential is, let's suppose threshold potential is minus 70 millivolt. Now what does it mean? Normally what happens, if this cell is here, and if cell, this is our sample cell, this was a cell which was going to stimulate the next one. Now how this cell can stimulate the other cell is, normally physiologically is, in between them they are having which junctions? The electrical windows in between the cells. What are these electrical windows called? Gap junctions. So normally what happens, if this cell is undergoing depolarization, it will get sodium influx, and some of the sodium from this cell will trickle through gap junction into the next cell. This sodium will trickle into next cell. This sodium will take the resting membrane potential up to threshold, right? First cell load slight amount of cations into second cell, and second cell the resting membrane potential will go to threshold. As soon as it reaches threshold, voltage gated, which channels open? Sodium channels open. Lot of sodium comes in and it will go under depolarization. Once it is depolarized, remaining story all of you know that voltage gated, which channels are opening? Potassium channels are opening, as well as calcium channels are opening. So what really happens, that this is calcium, right? This red is calcium and this green I'm showing potassium. For some time, calcium keeps on coming in, potassium keeps on going out, so cell is gaining cation as well as losing cation, so net cationic balance is not disturbed, and that will produce a plateau phase. But a time will come when further input of calcium will stop, but potassium is effluxing at a very high rate, and when potassium is going very rapidly out, then it will repolarize with loss of potassium. Now, this electrical phenomenon which we have seen, that first cell puts some cations, especially sodium, through the gap junction to next cell. The next cell will take resting membrane potential to threshold. Voltage gated sodium channels will open. Depolarization is there. Then calcium input and potassium output together make plateau, and then heavy potassium going out will produce repolarization. Now, normally this cell has a very stable membrane property. What I mean by stable membrane property, that once it has come to the resting membrane potential, it will keep on resting. It will not automatically fire. It will keep on resting. It will not jump for nothing. This is a healthy myocardial cell. When again it will go to threshold, when it will only go again to threshold, only when this cell will again trigger some cations. Only then it should go up. Is that right? But sometimes what happens, this cell becomes sick. This cell becomes injured. This cell becomes defective. It becomes dysfunctional and it develops irritability. Now I will tell you how this cell may become irritable. One simple reason may be ischemia. If this cell develops ischemia, it means oxygen supply is more or less. Oxygen supply is less. If oxygen supply is less, one thing which before I go for that, I should tell you here, sodium potassium ATPases are working. What these sodium potassium ATPases are doing? That whatever sodium has come in, these ATPases will take them out. and whatever potassium had gone out, these ATPases will bring in. Is that right? So normally when it is resting, sodium potassium ATPases are working so that during depolarization, whatever sodium came in, it should be thrown out. And during repolarization, whatever potassium came in, it should be brought in, so that balance of the cell should be okay, right? Now you imagine that, let's suppose this cell develop ischemia, because many patients with ischemic heart disease suddenly die due to ventricular arrhythmias. What really happens? Let's suppose this cell develop hypoxia or ischemia. It means oxygen supply is less. If oxygen is less, do you think it will make more ATP or less ATP? Less. If ATP is less, do you think sodium potassium ATP driven pump will work? No. So what really happens? That when there is ischemia or there is hypoxia, then oxygen supply is less, ATP level is less. So when there is low ATP, that will lead to reduced function of, what is this pump? Sodium potassium ATPase. And this will create problem. Why? Because when this pump will not have enough ATP and they will not work properly, then during the depolarization, whatever sodium is coming in, can it go out? No, it means sodium is being trapped into cell. And when cell will develop, trapping the cations, can its resting membrane potential remain much negative? No, if it is not having ATP, its pump is not working, depolarization induced sodium which is coming in, it cannot go out, sodium start accumulating in, this accumulated sodium, right, it will make the resting membrane potential less negative. It means this accumulated sodium will take the resting membrane potential towards threshold. So resting membrane potential will start fluctuating like this due to accumulation of waves of sodium. This is one problem. Second problem, when during ischemia membrane is really injured, physically injured, when myocardial cells are physically injured by ischemia, their membranes become leaky. And you know, normally sodium concentration outside the cell is very high, as well as calcium concentration is very high. So these cations will leak in, and if they leak in, again cation loading. It means ischemia can produce cation loading in two ways. Number one, it can load the cation by slowing the ATPases. Secondly, by simply damaging the membrane, and it cannot prevent the extracellular cation from coming in. This is one way. And of course, whenever cation will be loaded, resting membrane potential will become less negative and it will start fluctuating. Yes. And if during fluctuation, if it touches, by chance, if it touches the threshold, a pathological action potential is produced. It was unwanted. This cell has produced an ectopic firing because this time this cell was not stimulated by normal pathway. It auto-fired, right? And we say this is an ectopic firing, unwanted firing, irritable firing. Is that right? Then there are other things also which lead to cationic loading. Another classical example of cationic loading is, okay, you will tell me. You know, we say the people who have ischemic heart disease or angina or myocardial infarction, we keep on telling these patients that they should not be mentally stressed, they should not become too excited, they should not become too much emotional. Why? Because when they become emotional, when they become excited, when they become physically too active, they load the cation in the cell. Question is that how? Let me tell you. For example, this is a patient who has already ischemic heart disease. Due to ischemia, some cells are already loaded with cations. At the top, they become angry or excited, they put more cations. How? When you are angry, you will release adrenaline. You know it. And adrenaline will bind with the receptors here. You know, heart has beta 1 adrenergic receptors. So when adrenaline will bind here, when patient with heart attack, if they become angry or excited or tense, they release adrenaline. This adrenaline will bind with the receptors, and these receptors will stimulate a protein inside the cell, which is called G stimulatory protein. This G stimulatory will stimulate adenylyl cyclase. And this adenylyl cyclase will convert, yes please, ATP into cyclic, yes, AMP. Cyclic AMP will stimulate an enzyme called adenylyl. Oh my God, this is adenylyl cyclase. Cyclic AMP will stimulate protein kinase A. You are young man, your memory should be better than mine. Listen. Adrenaline stimulate adrenergic receptor which stimulate intracellular. G stimulatory which stimulate adenylyl cyclase which convert ATP into cyclic AMP. More cyclic AMP stimulate protein kinase A. One of the functions which protein kinase A do, that they phosphorylate some of the calcium channels. And when these calcium channels are phosphorylated, more calcium will come in and cell will become further loaded with cations. So whenever you shoot adrenaline in your body, whenever such patients become angry or excited or emotional, right? Adrenaline is shot is going up. When adrenaline level is going up, it is basically loading the cations in myocardial cells. Of course, when they are loading the cations in myocardial cells, resting membrane potential start fluctuating, undulating movement, and by chance if it start hitting the, what is this, threshold, it auto fires. This time now, ventricle will not be under the control of SA node. Maybe if this is an irritable cell and it repeatedly fires because it is loaded with cations, that will lead to dangerous tachyarrhythmias and the left ventricular. Okay, this arrhythmia will be in the left ventricle or more on the right ventricle more. Remember, both ventricles are electrically connected. There is no partition in between them. So it will be biventricular arrhythmia. So simply we call them ventricular tachyarrhythmias, right? Now, we were discussing that let's suppose this cell is irritable. This cell is loaded with cations, maybe due to ischemia, or maybe due to hypoxia, or it may be due to inflammatory mediators, or it may be loaded with cations due to adrenergic crisis. So whatever the reasons, now it can fire automatically. How the activity of this cell will be displayed on the ECG? Let's have a look. Suppose this is normal ECG pattern going on. Now look, at this particular moment, this pathological cell has fired. When this pathological cell will fire, it will not wait a stimulus to come from the SA node. It will auto fire, and when it will fire, the current which is coming out of this cell, this will not pass through normal conduction pathway, this will pass through a pathological pathway, right? And when this current is passing through pathological pathway, so that will make a pathological vector there, not a normal vector. So naturally the QRS complex will be abnormal. This is an abnormal QRS complex. It's wider. Why it is wide complex? Simply because that this is abnormal ectopic focus, and current which is spreading through this is not passing through normal high velocity pathway. So it's through moderate velocity, so it has to be wider, number one. Number two, that it has abnormal morphology, the reason being that current is again not coming through bundle of hairs and making a normal vector, right? For example, normally a vector, major ventricular depolarization is directed like this, but in this pathological condition, it may be directed like that. So naturally, what really happens, that your QRS complex will be of abnormal morphology. But if it gives only one fire, after that again, normal ECG pattern will re-establish. A normal ECG pattern will re-establish. And then, if you really look at the tracing, you may find another abnormal activity. Now, this type of abnormal firings, this one or that one, these are called ventricular premature beats. Ventricular premature beats. We simply call them VPBs, ventricular premature beat, because this ventricular ectopic focus fires before the normal beat come, right? They prematurely fire. So we call them ventricular premature beat, or other name is ventricular systole. Is that right? Now, if they are occasionally coming, they are not considered dangerous. But if they start appearing very frequently, then it's a dangerous sign, right? So if sometimes what happens that when normal ECG pattern is going on, a run of ventricular premature beats appears. And then again a normal pattern start. Now in this particular case, what we really say that there is one ectopic focus. Attention please, look here, all of them have same morphology. So one ectopic focus has fired many times repetitively. But here you say this morphology is different and that morphology is different. It means this is a different ectopic focus and that is a result of a different ectopic focus. Is that right? But here one ectopic focus has given multiple runs. So if it is really more than 120 beats per minute, and so then we may call it, yes, what do you call it? Ventricular tachycardia. Run of ventricular tachycardia. So we can say that if ECG pattern you continue studying, right, then what may happen, that normal ECG is going on. Now I will make gradually more worrisome changes in ECG. Here there is 2 abnormal firing, what is it now? Ventricular tachycardia. This was ventricular premature beats, the double fire, then it is ventricular tachycardia. Then you look here. What is this? Yes, you will tell me. What is it? This is called ventricular, yes please, flutter. This is curved wave. This is called ventricular flutter. Ventricular flutter occurs when one focus may start firing and driving the ventricle so fast, somewhere between 250 to 350 electrical stimulation to ventricle per minute. So this is called ventricular flutter. But remember, if ventricular flutter continues for significant time, if ventricular flutter continues for significant time, then heart mechanical activity cannot follow so fast electrical activity. This is showing the fast electrical activity, flutter activity, but mechanically heart failed to pump. So it means if flutter continues for longer time, then naturally cardiac output will dangerously drop. When cardiac output will drop, then multiple hundreds of areas of severe ischemia will appear in the heart, and every area will start firing on its own. And when hundreds of the areas start firing simultaneously, we say there is onset of ventricular fibrillation. Again, let me repeat. When ventricles are undergoing fluttering, electrical flutter, it means that even though electrical activity is around 300, but there is no mechanical activity. So naturally cardiac output is not there. So coronary flow will stop, and multiple hundreds of the areas of severe ischemia will develop within the ventricle. And if all areas start firing automatically, then it will become ventricular fibrillation. Now let's see the difference between flutter and fibrillation. Usually in flutter there is 1 or 2 centers which are firing very rapidly. But in ventricular fibrillation, there are many centers, many ectopic foci which are firing very rapidly. And in case of flutter, then naturally, it will become like little baseline fluctuations and then What is it here? What is it? It is death, right? Because flutter has left to the ventricular fibrillation. What is it here? Ventricular fibrillation. And ventricular fibrillation, if you don't treat well and rapidly, then it may lead to flat line, no electrical activity in the heart. Is that right? That may lead to death. So, can you recognize these four patterns? That if you look at ECG, where are the VPPs? Can you see a run of ventricular tachycardia? And whenever there's sinus movement like this, what is this? Ventricular flutter. And if it becomes fine oscillations, what is this? Ventricular fibrillation, right? And if you fail to control this, then of course, or fail to revert it, right, patient may go to straight line. So this was some basic idea about the ECG and cardiac arrhythmias, right? It was very, very basic idea, not advanced studies. When we'll study for step 2 and step 3, then we'll talk advanced study about this.